talk about the treatment in the emergency setting of a hemophilic with a head injury. Several important questions in addition to basics include type and severity of hemophilia. Does the patient have a history of an inhibitor antibody? Factor concentrate normally used and when their last treatment was. Where the patient gets their routine hematology care. And then the nature of the injury. Specifically looking for risks of coup contra coup injury or other serious intracranial issues. Also looking for a risk of facial bone fracture or dental injury. So what factors what? Here's a list of factors that are commonly used in the market today by brand name. Factor 8 products are listed to your left, and Factor 9 products are listed to your right. In the physical assessment, one of the things you want to do is look for the medical alert ID. This is going to help you with your history, and it's going to help you with contact information. So if they have one, try to look for it and find it. In terms of a rapid assessment, you want to look at their vital signs to look for Cushing's triad for intracranial hemorrhage and increased intracranial pressure. You want to look at a Glasgow Coma scale. You want to look at confrontational visual fields if the patient can do those. Primarily looking for evidence of a blowout fracture or other obstruction to the external ocular muscles. You want to palpate the surrounding face and skull and teeth, looking for additional injuries. And then you want to do a rapid assessment, looking for injuries elsewhere. And then in the process of your physical exam, you want to establish at least one free-flowing IV because you're going to need to give the kid factor quickly, and you're going to need other reasons to have that IV, especially if they need to have surgery. Cushing's triad. Increased intracranial pressure is manifested in the vital signs by increasing pulse pressure manifested by systemic hypertension and diastolic hypotension. It's seen in association with bradycardia and irregular respirations. This is the Glasgow Coma scale for adults and older children, and again, looking at a score of 8 total or less being a sign of severe brain injury. And then this is the Glasgow Coma scale for infants and toddlers, and the same concern, 8 or less. And then both scales are described both in terms of the total number as well as the highest score in each of the sections. A couple of golden rules, and these are really, really important to never violate. First rule, what happens on the outside of the skull has no necessary connection to what happens on the inside of the skull. You can have very, very ugly looking hematomas and very ugly looking bleeding events on the outside of the skull that have no bearing or no impact on the brain. And you can have very subtle bleeding on the outside of the skull that have devastating impact on the brain. So scans always have to get done, and caution with rapid discharge from the emergency room setting without good follow-up needs to be made, because these are patients who ooze blood and can get sick in a hurry with a very small amount of bleeding. Second, never let a patient leave your site without having had factor first. Never send them to CT scanner without being treated first, then scanned. And the reason being is that patients going to scanners wait around to get their scan, they wait around to come back, and all the while they're oozing blood. This is actually one of the most common causes of mortality in the emergency room setting in hemophilic head injuries. So never violate this rule. Factor first. Always remember, factor first. Standard factor dosing for severe bleeding. This encounters head bleeding as well as bleeding into the large muscles of the thorax, the organs of the thorax, or pelvis. Factor 8 is given at 50 units per kilo, which will raise you to about 100% of factor activity. Remember, 1 unit per kilo raises your factor 8 level 2%. Factor 9 is dosed at 100 units per kilo bolus because it's a smaller molecule and doesn't stay in the plasma very long. Inhibitor patients are a special group. These are kids who have an antibody that destroys their missing factor. A patient with a factor VIII inhibitor can receive vast quantities of factor VIII and have no benefit at all. And so these patients are treated with bypassing agents. And the bypassing agents that are commonly available are Novo7-RT or FIBA. Novo7-RT is dosed as 90 micrograms per kilo IV over every 2 hours times 3 doses. A megadose Novo7 dose of 270 micrograms per kilo every 6 hours has been done, but generally in a new patient would not be the starting recommendation. FIBA is 50 to 100 units every 6 hours, and our standard approach is to use one product or the other, but not both, although there are exceptions where the two drugs are staggered, but these are rare. On other initial therapy, these are kids who require a stat hemo call. They require a PICU admit for injury to the head, neck, or thorax. The head injuries can cause intracranial hemorrhage. The neck can cause compression of the airway. Thorax can cause airway compression, but also bleeding into the large muscle groups can cause hypovolemic shock. CT scan without contrast. Remember, you're looking for acute blood after factor. Remember, CT is always done after factor. Appropriate surgical consults are then done, and stat neurosurgery consult for anybody who is suspected or proven to have intracranial hemorrhage issues. A CBC should be done to look for baseline hemoglobin and a type and cross match for 2 to 3 units of packed red blood cells, depending on the nature of the bleeding. Okay, so if you have questions regarding this, please give me an email, and thanks for your attention. Bye-bye.